Welcome to this explainer. Today we're diving into a high-octane, rapid-fire review of high-yield pneumonia concepts, specifically designed to help you absolutely crush your medical board exams. If you're a focused learner looking to maximize that score, well, you are in exactly the right place. We're going to strip away all the fluff today and focus purely on the patterns, the mnemonics, and those classic clinical vignettes that examiners just love to test.
Here's our game plan for today. We'll hit etiology and high-yield bugs, move into severity scoring, talk through empirical treatments, cover VAT prevention, and finally, wrap things up with complications and pathology.
All right, let's jump right into Section 1, Identifying High-Yield Pathogens. Okay, so let's look at this direct contrast. You've got your typical bacteria, like Streptococcus pneumonia, which are clearly visible on a gram stain, and importantly, they respond to beta-lactams. But then you have your atypical organisms, like Mycoplasma pneumonia, Klebsiella pneumonia, and Legionella species. Guys, these are the ultimate exam trick. They are not visible on a gram stain, you can't culture them on standard media, and here is the real kicker. They are intrinsically resistant to all beta-lactams. So if your vignette describes a patient who just isn't responding to amoxicillin, you've got to think atypical, and pivot immediately to a macrolide, a fluoroquinolone, or a tetracycline.
Speaking of atypicals, let's talk about a board favorite, Legionella. You probably know the classic board exam trope, right? It's a chain-smoking grandpa who just got back from a cruise or stayed in a big hotel. That's because it's waterborne, not spread person to person. Examiners also love throwing in risk factors like smoking, male gender, or diabetes. And please, remember this massive exam pearl. The urinary antigen test for Legionella is highly specific, sure, but it only detects serogroup 1. So a negative result absolutely does not rule out the other serogroups. Keep that in your back pocket.
Moving right along, let's hit Section 2, Severity Scoring, specifically looking at CURB 65.
Knowing when to actually admit a patient is a guaranteed question on your boards. So let's break down this mnemonic so it literally anchors permanently in your working memory. Memorize this table because every single criterion grants a point, and that total dictates whether your patient can safely go home or needs an immediate hospital admission. Okay, C is for new onset confusion. U is for a blood urea nitrogen greater than 7 millimoles per liter. R is a respiratory rate of 30 or more breaths per minute. B is for blood pressure. Specifically, we're talking a systolic of 90 or less or diastolic of 60 or less. And finally, 65 is simply for an age of 65 years or older.
So why does this matter? Well, check this out. A CURB 65 score of 3 carries an overall 30-day mortality of 22%. If they hit a 3, you must hospitalize them and seriously consider the ICU. Just compare that to a score of 0, where the mortality is barely 1.5% and outpatient treatment is perfectly fine. It's a huge difference. But watch out for this classic exam trap. While the Pneumonia Severity Index, or PSI, is definitely more robust with its 20 variables, neither the PSI nor CURB 65 acts as a direct ICU admission criteria. The crucial point here is that these scores assess overall mortality risk, not specific ICU need. Direct ICU admission relies on actual, major criteria, things like septic shock requiring vasopressors or acute respiratory failure that requires intubation. Don't let the test trick you into using CURB 65 as your sole trigger for the ICU.
All right, Section 3, Nailing Empirical Antibiotic Choices.
Picture this scenario. A patient has a post-influenza necrotizing pneumonia, gross hemoptysis, and cavitary lesions. That right there is a screaming hint for community-acquired MRSA. So, you're the doctor. Which empirical antibiotic is your absolute best choice here? Vancomycin or linezolid?
Linezolid wins, hands down, no contest. And here's why. First off, it has way better lung tissue penetration. Second, it's a protein synthesis inhibitor, which means it literally shuts down the production of the Pannin-Valentine leukocidin, or PVL exotoxin, which is the exact thing causing all that nasty necrotizing tissue damage. And third, the clinical data actually shows linezolid is 15% more efficacious than standard-dose vancomycin in ventilator-associated pneumonia. In fact, vancomycin actually has a staggering 40% clinical failure rate in those cases.
That perfectly sets up Section 4, Vape Prevention and Treatment. So, ventilator-associated pneumonia, or VAP, is defined as an onset of pneumonia 48 hours or more after mechanical ventilation. And the single most important risk factor for VAP, it's the endotracheal tube itself. It basically acts as a direct highway right into the lungs, entirely bypassing our natural mechanical defenses. It lets pooled secretions microaspirate right around the cuff. And even worse, it forms a protective glycocalyx biofilm on the surface of the tube that literally shields the bacteria from your antibiotics. Because that tube is so incredibly dangerous, boards absolutely love testing prevention strategies. So seriously, drill this checklist into your mind. Keep the head of the bed elevated at 30 to 45 degrees, mandate daily sedation holidays, use subglottic secretion drainage, and above all else, avoid intubation if possible, and always aim for early extubation.
And finally, Section 5, Complications and Pathology Stages.
So the most common focal complication of community-acquired pneumonia is an empyema. If your patient is still spiking a fever and has leukocytosis after 4 to 5 days of appropriate antibiotics, you've got to suspect an empyema. You diagnose it by tapping and looking at that pleural fluid. If the pH is low, specifically under 7.2, along with a glucose under 2.2 millimoles per liter and an LDH over 1,000, boom, that's an empyema. And the key exam takeaway here: a simple parapneumonic effusion with a pH over 7.2 is self-limiting. But an empyema? That mandates immediate chest tube drainage.
Let's trace the actual histological stages of lobar pneumonia, just like a story. It starts with congestion. You get a proteinaceous exudate and bacteria flooding in. Then comes red hepatization. Erythrocytes fill that exudate, giving the lung a red, firm, liver-like consistency. Next is gray hepatization. Those erythrocytes are lysed, and now neutrophils and fibrin predominant. And lastly, resolution, where macrophages swoop in and clear out the debris.
Now, here is the absolutely crucial exam buzzword to look out for: gray hepatization. Examiners will describe a biopsy or a histology slide. The exact moment the lung enters that gray hepatization stage, the patient's gas exchange actually begins to improve. Functionally, the bacteria have been completely contained and eliminated from the histology. If the question specifically says the bacteria have disappeared, you know for sure you are in gray hepatization.
As we wrap up this explainer, I really want to leave you with this final thought. We've talked a whole lot today about aggressive empirical treatments, but the data clearly shows that for most VAP cases, a 7 to 8 day antibiotic course is just as effective as a 14-day course. Given that shorter courses are proven to be effective, how will you adjust your future clinical practice to stop driving dangerous multi-drug resistance? It's a critical question for the next generation of physicians. Thanks for joining me for this rapid-fire board review, and I'll catch you in the next explainer.